Dear colleagues, dear friends, welcome to this webinar entitled Will the SELUTION DeNovo study results impact your future treatment options? So the use of DCB is really one of the most interesting fields in the treatment of coronaries. We have been using them for quite a long time already for restenosis, but now the use in the Novo lesions in the recent year has gained a lot of interest due to potential advantages of really leaving less metal in the coronary arteries as we treat them. And I think really this trial SELUTION DeNovo study has represented a breakthrough for the use of this technology in the Novo lesions. So we want to learn a lot more about this trial, and we have here some of the most important investigators of this trial to get the details. And apart from that, I think one of the other important objectives of this webinar is to understand how to perform this procedure. So if you are thinking on starting treating some de novo lesions, first, which type of patients would you treat using DCB instead of drug-eluting stents, and also how to perform the procedure. So the practical aspects, tips and tricks on how to perform these procedures to obtain good results. So really, we have a very interesting agenda for today. If we can show the agenda. First, as I said, we will discuss the highlights from this SELUTION DeNovo study and what the data tell us. And for that, we will have the pleasure of having one of the PIs, Dr. Simon Eccleshall. After that, we will discuss a little bit more about the type of patients that we are selecting, how and when to use DCB for de novo lesions after the results of the trial. We will have Dr. O'Kane for this part. And finally, we will have a very practical part with case discussion on clinical algorithms with Dr. Thomas Rissanen. So really very, very experienced colleagues in the use of DCB in the Novo lesions. Of course, it's very important always for the success of these webinars that we have your participation. So please give all your comments and questions. You have the option to send them, and I will be checking your comments and questions and introduce them to our colleagues here, to our experts. So without more delay, I'm going to introduce Dr. Simon Eccleshall from UK to tell us a little bit more about the details of the SELUTION DeNovo study. Please, Simon.
Great, thank you very much. So it's a great pleasure to get to talk to you about the SELUTION DeNovo study. I'm sure a lot of you will have already seen the results, but we're going to go through them again now and see what this data tells us. That's my disclaimer. So DCB has been around for a long time, as Neve has just said, and I think the important thing to bear in mind is that paclitaxel balloons have been around for over a decade, and these were the first generation balloons that solved the problem of how to get a drug to the blood vessel wall quick enough. The more modern drug-eluting balloons, what we're looking at here is a sustained drug retention, homogeneous distribution, and better targeting of both the restenosis triggers and possibly also the thrombosis and inflammation that comes with ACS and with angioplasty injury. So the SELUTION SLR Drug-Eluting Balloon, as you're probably all aware now, is a balloon that delivers the drug using the concept of sirolimus mixed with a biodegradable polymer. It's the type of polymer you'll see on a drug-eluting stent, and it gives a controlled release of the sirolimus into the blood vessel wall, and it has a phospholipid coating that delivers the microreservoirs to the blood vessel wall appropriately, keeping it bound on the balloon during the transit through the patient to the coronary artery. So does this actually work? This has been looked at by a Lope Finn's group. They studied 27 animals with 3 different devices between the SELUTION balloon, the Magic Touch sirolimus balloon, and the Xience drug-eluting stent, with different vessels at different time points in these animals. And what they showed is essentially that the SELUTION SEB delivers drug over the same time period to the same extent as a standard drug-eluting stent does. So that's telling you that it's there for long enough to do all the work that we're hoping that it will do. So this study, the SELUTION DeNovo RCT, was presented by Christian Spalding at TCT very recently, and I'm the other PI of the study, and I've used his slides and modified them slightly from his original oral presentation at TCT. So we all know that drug-eluting stents seem to work, but actually when you look at longer-term follow-up, you see that there's an attrition rate of something over 2% per year, whether or not it's a bare metal stent, a drug-eluting stent, first generation or second generation. And as you can see on the right-hand side of that graphic, all of them seem to have a very similar attrition rate after landmark analysis at 1 year. And in fact, there's data showing that this now continues out to 10 years. So the concept of a balloon-only approach is to try and reduce the event rate that you would get long-term in these patients with known coronary artery disease. And the question is, can sirolimus do even better, or at least as good as paclitaxel in this setting? So the SELUTION DeNovo study design, I'm sure you've all seen this before, but I'll walk it through you through it very quickly. It's prospective, randomized, open label, multicenter, and non-inferiority trial. What we were looking for were patients who were going to undergo angioplasty, and as long as they fulfilled the usual criteria, they were randomized before they started their procedure. So either to a drug-eluting balloon strategy or a drug-eluting stent strategy. And the first co-primary endpoint was non-inferiority for target vessel failure at 1 year, which is a composite of cardiac death, target vessel MI, and clinically driven target vessel revascularization, with a second co-primary endpoint at 5 years of non-inferiority, and if that is proven, then testing for superiority as well. So the point of all of this is a strategy trial. It's a strategy of, I'm going to use the solution balloon, but except occasionally I'm going to have to use a stent, against I'm going to stent everything. So the key inclusion-exclusion criteria are listed here. Essentially, all target lesions needed to be amenable either to the balloon or a stent before randomization. The reference vessel diameters were between 2 and 5, and there was no limitation on the number of lesions or vessels, with the exception that we didn't want people to put so much work in that they knew that they were going to be bailing out at least some of the time in the balloon arm. We were accepting up to 30% bailout, and as you'll see later on, that wasn't a problem. But what we don't want is every patient to be bailed out because you've done so many lesions. The key exclusion criteria are STEMI, unstable, non-STEMI, left main stem, any graft, CTOs, in-stent restenosis. And I think all of these will be addressed in separate trials, or already have been addressed in that setting. The other slightly unusual one perhaps is previous PCI in a target vessel. We did this very specifically to avoid those late stent-related problems that I just told you about in vessels that we were now treating as part of the trial. So the procedural guidelines, if you're stenting, you just stent in the usual way that you do. If you're using the DEB strategy, we wanted optimal lesion preparation with mandatory 1-to-1 balloon-to-artery ratio sizing as judged by the angiogram. You use the SELUTION SLR DEB with a minimum inflation time of 30 seconds. You can stent if there's a residual stenosis or recoil of over 30%, if there's a vessel-threatening dissection, or if physiology is still telling you that that vessel is ischemic. In addition to all of that, use of adjunctive devices was according to operator preference, such as any cutting, scoring, or high-pressure balloons, any calcium modification, any imaging, and any physiology. Antithrombotic regimen was based on guidelines and local practice. And if you were doing a staged procedure, these were allowed but needed to be done within 45 days of the index procedure. Here's the study organisation. I have to say it's the first time I've been involved in anything like a study of this size, and I was amazed at how good everybody was and how much work it all involved. Speaking of all the work involved, here are all the centres with the country PIs and centre PIs listed. 62 sites, 12 countries. It was an amazing job and recruited very fast by these large trial standards. Here's the statistics. As I said, the primary endpoint at 1 year, which is what we're talking about currently, was target vessel failure as listed there. It's important to note that the assumed event rate was 6% for both arms, and this was based on previous drug-eluting stent trials of similar cohorts as we could find, and what little data there was out there for similar DCB trials. The non-inferiority margin was a very standard 50% non-inferiority margin, which you can see in any of the relevant publications. And this was overall target vessel failure in both arms. And this is really important because this guards against the problem of low event rates. If you have a fixed margin and low event rates, you run the risk and criticism of claiming non-inferiority when actually your margin is so large that non-inferiority may not actually be the case. As you can see, it was powered to 95% with expected loss to follow-up of 2%, sample size of over 3,300. So on the right is the example that if we did have event rates of 6% overall, that non-inferiority would be met if the upper-sided 95% confidence interval fell within that. But obviously that will change when we know the actual event rates. So the consort diagram for our patients, 3,341 were randomized. You can see a few were excluded along the way because they didn't undergo an angioplasty. And again, this is really important from the point of view of, is it an intention to treat or is it a full analysis set? Our analysis was on the full analysis set, as you can see there. And we had those numbers at the bottom with 98% 12-month compliance, which I think is quite impressive. So the baseline clinical characteristics, as you can see, are here very standard for a PCI randomized controlled trial these days. You can see high bleeding risk at somewhat under 20% and acute coronary syndromes at just over 30% of the cases. Angiographic characteristics, I was delighted to see that proximal LAD was nearly 1/5 of the whole study population. Device size, which is how we judged vessel size, was 2/3 equal to or greater than 3 millimeters, so telling you that it really is an all-comers study with lots of large vessels. Moderate to severe calcification in around 1/4 of cases, and type B2 or C lesions, again in about 2/3 of the cases. Procedural characteristics, it's European, so it's nearly all radial. Specialty balloons were used more often in the balloon arm than the stent arm, and those numbers would reflect, I think, probably current European practice. Calcium modification was relatively low in both arms. Imaging was somewhat under 20% in both arms, again, I think reflecting European-wide practice, and was mostly driven by Peter O'Kane and the rest of the UK team. The stenting rate per patient in the DEB arm was around 20%, as in 80% of patients completed all of their procedures without the need for a stent. The procedural duration time is actually quite long, suggesting that we were doing quite complex patients and quite a few lesions and vessels. Here's the primary endpoint that I'm sure you've already seen. Drug-eluting stent, target vessel failure 4.4, solution DEB 5.3. So non-inferiority is met with a margin of 2.44 because that's what half of the actual event rate is, with a p-value, as you can see, of 0.02. So non-inferiority was met, which was obviously fantastic. Components of the primary endpoint, well, we're not powered to look at the differences between these, but people are already getting a little bit hung up about the fact that clinically driven TVR seems to be a little bit higher in the solution DEB arm. This actually has been seen quite often across all sorts of DCB studies already, and there is some operator bias that certainly comes into repeat revascularization, as well as the fact that to some extent revascularization in this setting is more of a choice than an event, I suspect. But if you're worried about the higher TVR rate in the balloon arm, maybe you should be worrying about the higher cardiac death rate in the stent arm as well. We can talk about all of this later. What about the secondary safety endpoints? I think the really important thing here is all those people that worry about coming back to the lab in the middle of the night because I didn't put a stent in. Here you can see that the safety endpoints are phenomenally low across the board, and this backs up previous DCB trials. Subgroup analysis, here's the usual forest plot, which looks quite busy. The things to pay attention to is there appears to be an interaction with sex, with high bleeding risk, and with moderate to severe calcification. And undoubtedly, we'll be looking at all of these in more detail in the future, but at the moment, there's nothing statistical that we can draw from the data that we have currently. So the limitations of this trial, it was broad inclusion criteria, but did exclude STEMI, CTO, ISR, left main, and grafts. And dedicated trials need to be done, I think, for all of these in due course. Lesion preparation reflects European practice. QCA analysis is ongoing and is not therefore available. And the study performed is very specifically with a SELUTION DEB, and the results can't be applied to any other DEB or DCBs. And as we say endlessly in all of these meetings at the moment, there is absolutely no class effect for drug-coated balloons. So the summary, it was a large trial, a pragmatic study, with the first one to have randomization before starting the angioplasty, so it's strategy rather than device randomization. There are no safety signal concerns. 80% of patients left the lab without a stent in the balloon arm. We think that therefore this study is relevant to the vast majority of PCR that we do day to day, and 5-year follow-up will tell us whether what we believe to be true will be seen in that non-inferiority and hopefully even superiority with a minimal stenting approach will be the way that we should be practicing. So at 1 year, a strategy of PCI with a solution balloon and provisional drug-eluting stent in a small proportion of patients was non-inferior to systematic use of drug-eluting stents for the primary endpoint of target vessel failure, or to put it a different way, I think this is a game changer. My second conclusion slide is I think PCI is changing. I think optimal lesion preparation is now where the focus is and should be. And after that, you can choose your destination therapy, which could either be a drug-eluting balloon or a drug-eluting stent or a scaffold. Thank you very much.
Thank you, Simon. That was great. Actually, we have already some questions from colleagues here, and I think it goes very well with your last slide that I fully agree with, is how PCI is changing and should change, actually. And it's about the lesion preparation. So one of the colleagues joining the webinar has a question about the lesion preparation in both groups. So was lesion preparation, different in both arms? It was in the protocol, mandatory, more lesion preparation in the DEB arm than in the DS arm. That's the question.
Thank you. Yes. So what we tried to do was make it as pragmatic and as real world as we could. And we know that still the vast majority of stenting isn't necessarily done with the same degree of optimal lesion preparation that is done for a DEB approach. So in the stent arm, people were allowed to do what they normally do, which would be either just a simple pre-dilatation and then a stent and then a post-dilatation, plus or minus whatever imaging optimization they would like to do. Whereas in the balloon arm, yes, it was all about optimal lesion preparation as per the most recent consensus document that we probably need to update now because it's a few years out of date, but very specifically looking at optimal lesion preparation with all the safety signals based particularly on the angiogram that we've used previously. So yes, in some ways, the lesion preparation is different between the two, but we believe that this currently reflects real-world practice generally. Although I do think that lesion preparation now will become more mainstream and drive lower event rates across the board for all our patients with PCI, which has got to be good.
Yeah, definitely. I always say that one of the best things that TCB is going to bring, apart, from more options for our patients, which is, the most important, is really, going back to good angioplasty. So really,
Yeah,
not get away with no prep and just implanting a stent that always looks good in angiography. For this,
sure.
you really need to work on your preparation. I think this is actually one of the things that the increase in DCB PCI is going to bring is better PCI.
Yeah.
In general, that's what I think. Um, in any case, so of course, it's intriguing to see when you see the subgroups, and I know you don't have the information, but we're going to keep asking you that about the subgroups. I know the analysis is not done, but it's interesting to see that there are some subgroups that look like they could potentially benefit even more no from this big treatment, and one of them is the calcium group, no. And
Mm,
this is really interesting because probably when somebody look at the data, some of the initial thoughts would be, okay, this is kind of not very complex lesions because, for example, the use of um, preparation balloons was kind of low. But on the other hand, then you see that when you have calcium, it looks like these lesions, could even benefit more. We don't have all the details, but what I mean is this is not like a simple lesion population. It looks like also some kind of complexity was included in the trial. Can you clarify a little bit, Simon?
yeah, so like I said, we tried to make it as real world as we could, and we know that all our angioplasty is becoming more complex with time, and the amount of calcium that we're dealing with, it seems to be becoming more prevalent in all of our procedures. So all of these things were allowed within the trial, and I think we showed with the demographics that yes, it was quite a complex cohort. It wasn't specifically enriched, but it was certainly complex enough for most of us for most of our work. I think the calcium one in particular is interesting. We have looked at in our large database locally in our own hospital at calcium outcomes with DCBs against stents. And interestingly, the only difference seems to be in our hands that target vessel MI is actually higher in the stented group than in the DCB group. And I wonder whether this makes some sort of sense related to all these calcium nodules that you fight against forever, and it affects the stent deployment in a way that, in some ways, delivering just a drug-coated balloon is much more forgiving to it. Although across the board, calcium still is a predictor of a higher target vessel failure.
Hmm. Yeah, one of the other question we have from our colleagues joining the webinar, and I think is one that probably many people have. I think it goes also with your first slide. Like this is a strategy study, and I think it's reflective of real practice. So you try to treat the lesion. Your intention is to treat it with DCB, but of course, if you need to implant a stent, this is completely allowed. Let's say,
Yeah.
but there are some questions because of course there's a 20% of patients where in the end a stent was implanted in the
Mhm.
arm. And there are questions about whether is there any comparison about the devices themselves, patients that were treated only with DCB or patients treated with DS, either in the DES arm or patients that in the end in the DCB arm were treated with DS. Do we have any information about this, or is something that is going to come in the paper?
Okay, so we do have a little bit of that data. I think the most important thing to say is, whilst, because we've been asked this question a lot, people are very keen to know about just the DEB treated patients within the DEB arm. The whole point of the study was it was a strategy study. We're not trying to get rid of stents, we're just saying use stents less often. And what we've shown that is you can use stents a lot less often, as in only 20% of patients, and still get non-inferior results. Having said that, if you just take the DEB only patients out of the DEB arm, the target vessel failure rate was actually a bit lower. It was 5%. What that's telling you is that the patients that we did have to stent in the DEB arm carry a bit more of an event rate, which probably means they're more complex and perhaps there's been more work done. And if you're bailing out, that probably is because it's a higher risk lesion to have been in the first place. The really important thing, however, it does tell you is, before anybody asks the question or says it, is the stent rate in the balloon arm is not carrying the balloon arm to give you the non-inferiority, as in the more stents you put in, the better your results are going to be, if that makes sense. So they really are being kept only for those patients that really did need a bailout option for the usual vessel-threatening dissection or recoil.
Yeah, I think actually it's going to provide a lot of information really about the type of patients that can, that are optimal for DCB, or patients in the end that you need to use kind of a hybrid strategy, which is also, an option that we normally use in clinical practice. So I think, as you mentioned, this is a strategy trial, it's not a comparison of devices. And I think that's how the study should be interpreted. So thank you very much, Simon. There are lots of questions, but we will introduce them, later on. Let's continue with the next presentation from Peter. So, changing treatment options for PCI patients: how and when to use a DEB after DeNovo. Peter, please.
Many thanks for the invitation to speak at this webinar with such an esteemed panel. I'm Peter O'Kane. I work in the Royal Bournemouth Hospital in the United Kingdom on the sunny south coast. Here's my disclaimer. I'll be talking about using DEB after SELUTION DeNovo. For me, PALS is the guide when you want to try and avoid putting stents in. We came up with this concept with colleagues Jonathan Hinton, Jahangir Din, Paul Brady, and what we tried to do was think about how we could replace metal in our PCI practice. We worked with Optima, and we came up with a series of scenarios where this may be useful. So for the patient, younger people who are perhaps diabetic, have high bleeding risk, those who are more compliant, they may be beneficial to have DEB rather than stent. Anatomical features such as restenosis, bifurcation, long lesion, or calcium are sometimes better treated with DEB rather than DES. And for the patient, the long term, such as a 2% annual fail rate with DES, is something to be considered. You also may be able to image them without having long-term metallic prosthesis. Now, I've been practicing simple PCI and complex PCI over the last 20 years, and often we made simple lesions complex by putting 2 stents in this 001 example, but now we're able to make more complex lesions simpler by just using a DEB approach. That may have benefit to patients in terms of MACE. Now, in terms of the PCI principle, of course, we spend time assessing lesions with physiology and imaging and preparing with all the tools we have in our toolbox. And this allows us to consider whether we finish with a DES or a DEB. But treating patients with DES is not so straightforward. And without intracoronary imaging, I think we make mistakes because we can't always get the right size in both diameter and length. We may not avoid lipid pools. We sometimes don't end up finishing the case without mechanical problems that we can't see on an angiogram, such as edge dissection. So we have to be mindful that stenting is not perfect every time. An alternative, of course, is to use a DEB approach. We might be able to use, if we have less than 30% stenosis and good flow, or if we don't, we can always cross over to using a stent. Now, this is from the DCB consensus group, and I think it's a very sensible way to do it. I've given you here now an ABC, really even simpler way to try and use this approach. And this is how I think about things in the cath lab. So I try and aim for a stenosis less than 30%. I used a lot of non-compliant balloons, scoring, cutting. And in this example, I have to use calcium modification. So we start with a cutting balloon for this 180-degree arc. It's not sufficient. IVL is successful, and we're able to finish the case with the DEB. This A to F angiographic classification has been around a long time and still has a use. We try and avoid anything greater than a type B dissection. And to do this, we have to perhaps size with angiographic sizing. We have to use lower pressure and longer inflations. And in this example, intracoronary imaging is useful because it detects a medial dissection that hasn't propagated and is really quite safe to leave. Here, in this proximal LAD, after extensive lesion preparation, I end up with a dissection. You can see it looks more like a type C. But actually leaving this is not too bad. It does heal, and within 18 months, it looks perfect. So we don't have to cover these with a stent every single time. Simon's come up with this safe or leave or need to stent classification, which I think is simpler and more simple to use in everyday practice. Here I've used it in this example of a 50-year-old lady who came in with a troponin-positive coronary syndrome. You can see the angiographic severe stenosis confirmed on imaging with a small lumen and a large plaque burden. After lesion preparation with scoring balloon, cutting balloon, and non-compliant balloons, we end up leaving a dissection which is clearly angiographically visible. On the iris, we have an enlarged lumen, still a retained large plaque burden, and evidence of medial dissection, but it's very controlled, is stable, and does not need to be treated with a stent. And the patient comes back to have the LAD pressure wire, the right coronary artery is completely healed, and there's no significant late loss. Occasionally, it is necessary to cross over. If you have a type B dissection that's perhaps extending back to the ostium, as in this case, or it's more than a type B dissection, you might have to cover. Putting in a stent here is no problem. Abrupt closure is everyone's fear, but it's extremely rare. This was one case where I prepared quite aggressively, perhaps oversized the balloons, but I did achieve a stent-like result. 7 minutes later, however, the vessel abruptly closed and I had to implant some stents. Residual stenosis, more than 30%, is sometimes an issue, as in this long lesion in the LAD, and you have to put stents in if you can't achieve that. But actually, that's quite a rare scenario. The drug is sirolimus with the solution balloon, and it's really quite effective. As we've proven in the study, it has a 90-day profile, and these microparticles really allow the drug to penetrate into the tissue and give us this excellent result in the longer term. So restenosis is an area we already use it. Small vessels is an area where we use it. SELUTION DeNovo has confirmed it's safe and effective in this group, but also in large vessels. And what I will talk about now is how this might penetrate through our use of both drug-eluting stents and drug-coated balloons. And we were very fortunate in the UK because we were able to work as a team and deliver a third of the patients in the SELUTION DeNovo trial. And that means that actually as a group, we have quite a lot of experience now with using this type of technology. It's enabled us to think about this on an everyday basis and perhaps move forward from our current 10% of DCB use in the United Kingdom, perhaps expanding this. Now in restenosis, perhaps the guidelines suggest we should use more drug-eluting stents, but we're still going to be using 50% DEB in this situation. Now, smaller vessels, less than 3 millimeters diameter, they probably account for about a quarter of all the work we do, based on the fact that 24% of the stents we use are 2.5 millimeters. Now, it's important to realize that when we implant stents of this diameter, our ability to achieve an MSA more than 5 millimeters is quite restricted. And that's important because that is a marker of target lesion failure. So I'm going to assume that most vessels less than 3 millimeters should be treated with drug-coated balloons. Now, you've already seen the example of bifurcations treating simple and complex lesions. And just take this pretty simple bifurcation lesion. Putting the stent here and landing it at the ostium is not always so straightforward. You might more likely come more proximal, perhaps this could be a left main, or you may miss the lesion completely, have geographical restenosis at this point in the future. Crossover stenting, of course, is perhaps the best option in this scenario, but it has many steps and there's many opportunities for things to go wrong, such as longitudinal stent deformation. So a more simple approach, perhaps, is just to take this lesion, predilate it, get rid of the stenosis, and then treat it with a drug-coated balloon. I'm going to show you an example of this in the next case. A 60-year-old patient presents in March with ambiguity at the ostium of the LAD, and the angiogram is not clear that there is even a lesion there at all. There's a minor troponin rise, so we know something is amiss. The patient then has OCT to try and understand this lesion in more detail and define whether there is a significant stenosis or not. There's the OCT. It runs quite fast, but you can detect there is a stenosis here just at the ostium of the LAD. This schematic really tells you that the lesion here is 1.2 millimeters squared. That's quite severe, and it gives us our target vessel landing zones. Simple preparation with non-compliant scoring and then a larger non-compliant balloon give us a stent-like result based on this OCT run, and there's absolutely no need to consider implanting a stent. There's minimal dissection, which you could argue is not so effective because we want some dissection, but the area here is 5.9 millimeters squared, which is much improved. That's the final angiographic result, and I think you'd agree it looks like a stent that's been implanted, or there was never anything wrong with the vessel in the first place. Now, when we get to larger vessels, these are obviously the most important ones that we want to treat, such as proximal ADs and large caliber right coronary arteries. I think with the results from SELUTION, we might end up splitting this 50-50 between drug-eluting stents and drug-eluting balloons in the future. So that means 65% of cases may be treated with drug-eluting balloons. Now, surely things like left main that would be treated with stents, well, we're perhaps considering this in very few cases as pure DCB, but we are also using a hybrid approach, which I think is will be much more common as we try and avoid putting too much metal in. So treating the ostium of the circumflex is a good example of that. So my prediction would be in the future, it might take a long time, perhaps 5 or 10 years, that drug-eluting stents will be used fairly rarely on their own. Hybrid procedures will be fairly common, and drug-coated balloons will be used quite extensively. Thank you very much.
Thank you, Peter. That was great. So one of the questions, of course, is about imaging. There are lots of questions from the colleagues in the chat about that. The use of imaging in the Novo study, in SELUTION DeNovo, as Simon said, was kind of low, reflecting clinical practice, common clinical practice. But everybody's wondering because, of course, if we know that with DS imaging bring benefits, you could imagine that, of course, even with DB, this could be even more. No? So what's your take on that, Peter? How do you think imaging can help? Because I think one of the problems we have nowadays is also that we don't know exactly what is a good result with imaging, because we see a lot of dissections. People might be afraid to leave some lesions without understanding when they see a lot of dissections when they do, for example, OCT. I mean, how do you manage that you always use or almost always use imaging for your procedures? How do you manage this? What would you consider a good result for not to use a DCB when you use imaging?
Okay, it's a great question, and it took me years to learn to give a talk without opening my mouth. Now, I think it's an important one. For me, every stent I put in is pretty much imaged. So transgressing that into the SELUTION trial and with balloon, I adopted the same policy. For me, it was giving me learning on the morphology of the lesion and my landing zones. And then, as you said, the section characterization is challenging to understand as to whether that might cross you over or not. But in fact, it had the opposite effect for me and colleagues because it reassured us that with the imaging we could see, there wasn't a spiral dissection and there was less likelihood of that propagating and closing the vessel. I think there's a lot to learn. I don't think we understand it fully yet. We'll have some sub-analysis from this study, but I suspect we're going to need prospective trials of angiographic versus image guidance to really understand this better and to also get the characterization correct. We don't even have it perfectly for the angiographic characterization. We know that Simon has come up with a much simpler proposition to move away from the A to F guide. And I think that's really important. So for me, it's imaging is a key role, but it doesn't mean you can't do these cases without imaging. I think you still can. I think the study itself is we should congratulate this steering group and PIs and all the colleagues, because actually this was a very brave trial. And of course, Jeff Jump and Suzanne Mice, who were there at the very beginning, to actually invest time to set this up. It's incredibly brave. I don't think many people would have expected this type of trial. And I think we now have options that we've never had before. So a real great round of applause for everyone involved.
Yeah, I think Thomas, I think with your cases, we will have much more information also about the use of imaging. But definitely, probably it will happen like in DS. I mean, the benefit of imaging will be in the more complex lesions. I mean, if you're treating a very simple lesion, probably you will not get a lot of benefit, but it will help, I think, in cases where you're treating more complex lesions. That I think is also where probably DCB is going in this direction. As you said, you were mentioning these subgroups, where you think probably DCB will be very useful in the future, no? Like the most complex cases, like complex bifurcations where you want to avoid, for example, 2 stents, very long lesions where you want to avoid very long stents. What are your, what are the types of patients that you consider now from the beginning as
Yeah.
DCB?
That's a great question. And I think it's also important to mention this is a learning curve for all the operators in the trial, as well as I was learning. So we started off perhaps more tentatively taking on the slightly less complex lesions, but by the end of the study and beyond the study, we're doing some very complex procedures. And as you say, I think it's probably the more complex lesions that have the most benefit. So calcification, large vessels, and being prepared to leave the vessel not looking right, a stent has been put in, but knowing that over time that will heal. And that isn't something you can learn overnight. That takes time and experience. And I think the message, I would give to people out there is don't just leave carnage in your first few cases. Just take an adoptive approach to this and just say, I'm going to learn how to do it with more simple lesions and then progress to the more complex lesions. But I think that's where the benefit is going to be.
Yeah, definitely. I think it's, as you say, there's a learning curve and you should start always, with more simple lesions. But I think probably as you said, you find it even more useful when you have these complex situations, like bifurcations, long lesions, etc. So this is a question maybe for the three of you. One of the main fears, of course, when people start doing DCB is the acute closure. So you mentioned, Simon, the numbers on the study that were really very, very low. What is your advice for this? So are there any predictors where you could say, okay, this is a case that I'm going to stand because I think there's going to be an acute closure? Is there a time you always wait, from the moment you perform your preparation to decide if you're going to go for DCB? Like this very practical aspect. How do you do that?
Me personally, so there is no angioplasty that at the beginning I know I'm going to put a stent in. I'm always intending to have a DCB or DEB approach, bearing in mind I know I have stents on the shelf if I need them. I think the most important thing really is doing really good lesion prep to give you as much of the time as possible the option of any type of destination therapy, a balloon, a stent, or a scaffold. And as Peter mentioned earlier, I think simplifying the whole, what dissections can you leave and which ones can't you leave, is something that hopefully will help. And I think simplifying it basically to just saying, you've got to have TIMI3 flow, you've got to have good lumen gain, and you don't want a lot of contrast hanging up in the wall somewhere that stays around after all the contrast has left the vessel. And obviously on top of that, any horrendous big spiral dissection, as long as you're not seeing any of those things, they're all safe to leave. And all the trials such as Thomas's and Basket Small and ours, all of them show somewhere in that paper that as long as you're doing the right thing and following the sort of consensus documents that have been written, your acute vessel closure rate will be really low. We actually published thousands of patients that we've looked at in our own practice and looked at the return to the lab. And the return to the lab within the first day was actually lower in our hands. Well, similar between balloons and stents at 1 day. And by 30 days, it was already appearing to be lower in the balloon arm than the stent arm. But this just follows all the RCT stuff that's out there already.
Mm-hmm. So I think this is also important, and we're going to move now directly to Thomas' cases that I think are going to be very useful to understand that it has to be a balance between, good preparation and, a level of dissection, let's say, of the vessel that you can leave, of course, safely. So I think this is the balance that probably, for more complex lesions is part of the learning curve. You can also have a bad result and say, okay, it's not great, but let's put a DCB and it will be magic. No, I mean, DCBs, they don't do magic. You need to do a good angioplasty and then they will do their job. So I think this is probably what is more difficult when you start with your practice, is this compromising, good plaque preparation, really, good result, good lumen, etc. But some degree of dissection that you need to accept to let there. No? Okay, Thomas, so let's move to your presentations, clinical algorithms at work, treating de novo lesions with SELUTION with 2 case examples, please.
Okay, thank you, Nieves. It's my pleasure to add a couple of cases to this discussion. These are my disclosures. So the first case is a 64-year-old male. He had CAPITs almost 20 years ago and was referred to urgent coronary angiogram due to unstable angina. So in the angiogram, we found that the vein graft to RCA was occluded, the other grafts were open, and there were 2 stenosis in the native RCA, one in the proximal part and more severe in the distal part, just distal to the previous anastomosis. And if you look more carefully, you can see that there is no significant calcium, at least angiographically, and there is also some size variation, especially in the more distal lesion. I think this is also an important consideration regarding DCP or DES strategies. So as we also do, like Simon said in his cath lab, we also always start with a proper lesion preparation, and then thereafter we decide the final treatment of the lesions. In this case, we evaluated that the balloon size should be 1:1, and it means 3.5 NC ballooning for the both lesions. And then we had a look how they look, and there's now important question: can we treat these both lesions with DCP only, or do we need scaffolding? I think the distal lesion looks almost a stent-like result, and there is dissection and recoil in the proximal part. And if you look at the consensus document, it clearly says that if there is recoil over 30% or above type C dissection, you should do stenting or scaffolding of the lesion. But if the angiographic result is optimal or there is less than 30% recoil, TIMI flow rate is 3, then you can go with DCP safely. So that's what we did, and actually in this case we used McMorris scaffold for the proximal lesion, followed by post-dilatation with 3.5 NC balloon to high pressure, and SELUTION SLR DEB 3.020 1 minute lasting dilatation. And this kind of long dilatation, it also improves the BOBA result itself. Then we evaluate the final result optimally from 2 clearly different angles and the final picture without the wire, so that it doesn't seal any severe dissection. And you can see that in the distal artery where the DEB was used, there is non-flow limiting type A dissection. I think this can be called a therapeutic dissection because it enables the positive remodeling of the vessel. And we don't have the fear of stent malapposition in the part where the anastomosis was, because we don't have any scaffolding. And this patient had another angio 3 years and 4 months after the procedure, and you can see that there is positive remodeling of the DEB-treated lesion, and also a good result for the scaffolded part. So we were very happy about this result. Okay, this was a quite simple case, and the next one is a more complex one. So this is type 2 diabetic with COPD. He was frail, had mild anemia and dark for atrial fibrillation. So it means that this is a high bleeding risk patient according to the ARC criteria. The patient was admitted to hospital due to new onset systolic heart failure. Echo demonstrated a severely decreased left ventricular ejection fraction. This patient, of course, have a diagnostic coronary angiogram, and it showed a very calcified, diffusely diseased, and eccentric lesions in the LAD. There were no other significant lesions in the left system. The right system was also diseased, and we opted to treat it in a staged procedure. So the considerations for these patients are that this is an inactive, frail patient with COPD. So the decision was to go forward with PCI and no capids. The syntax score actually didn't tell everything about this complexity of this lesion. There's heavy calcification and diffuse disease. And also, very importantly, there's high bleeding risk. So our plan was to use 7 French radial, do first rotablation, and then imaging-guided PCI using DCP only or the hybrid approach, depending on the predilatation result. So we used the small 1.25 burr and did OCT on the right side. You can see that there is a good wire bias. The wire is against the calcium, and it's very heavy burden, in most parts circumferential calcium. We did rotablation to the 2 proximal stenosis with 1.75 burr. After that, we had a little bit slow flow, and we administered nitroprusside because of that. The patient's hemodynamics were good at all times. After that, we used a 3.0 cutting balloon for the mid and proximal part of the LAD, and then NC ballooning and 2.5 NC ballooning, 2.5 both LAD distal and diagonal at high pressure. However, repeating OCT, you can see that if you calculate MLA, it's suboptimal in the proximal part of the LAD, only 3.5 square millimeters, and still we see no sufficient cracks in the calcium. So we need to do more lesion preparation, either for DCP or stenting. We opted to use IVL using shockwave catheter, 3.5, 12, and all the pulses giving to the vessel. And after that, we could demonstrate good MLAs, 6.7, and there is nice cracks in the calcium. So at this point, you can choose either stenting or DCB. In this case, it's a long lesion, it's a bifurcation lesion, it's a high bleeding risk patient, so we went using DCP only strategy. So many SELUTION SLR DEBs were applied first to the side branch, and then starting from the distal artery, 3.75, 3.0, and 3.5 for the proximal artery. And this is the final result. You can see that the flow is good. I think the flow was already a little bit diminished before we did anything. The patient didn't have any chest pain, ECG was fine, hemodynamics were fine, and because of the bleeding risk, we gave only 3 months clopidogrel on top of DOAC. We did the planned second procedure because of the stage RCA treatment, and here we can see that there is a very good midterm outcome for this calcified lesion, and you can say that there is even a little bit positive remodeling. We have followed these patients already 21 months. There is no ischemic or bleeding events, and the ejection fraction was normalized at 1 year. So I think based on these two cases, we can conclude that, as Simon said, there is increased risk of MACE, especially related to long stents. The SELUTION DeNovo trial had indication that there might be especially benefit for in the subgroups of calcified lesions and HBR for DCB. DCB may be considered instead of stenting, especially in HBR patients. There is only 1 month DAPD recommendation, and there is some data supporting the concept of single antiplatelets after DCB in extremely high bleeding risk patient. And there is possibility of stopping antiplatelets. And then already observational data have shown before SELUTION DeNovo trial that calcified lesions actually are a good target for DCB. And we have to learn more about intravascular imaging, but in practical terms, it helps in sizing the predilatation balloon, evaluation of the lesion characteristics, and also calculating the MLA after predilatation. And in bifurcation, DCB simplifies the treatment. Thank you.
Thank you, Thomas. Two great cases. And I think this one, the last one you showed, I think it reflects very well the combination that Peter was talking about, the combination of the patient characteristics plus anatomic characteristics that can lead you to use DCB. It's a patient, as you mentioned, with high bleeding risk and with an anatomy that also favors probably using DCB to avoid a very long stent or very somehow underexpanded the stem in certain areas, etc. So I think it's a very interesting case. You mentioned that you use imaging also to evaluate the preparation. There was a question from one colleague about what is the MLA you can let to decide. I'm afraid we don't have this data. I think is something that is going to come in the future when we try to understand how to improve even more DCB PCI. But what is how do you use imaging? I think you were already in your answer, but do you want to elaborate a little bit more on this, because there were lots of questions from our colleagues.
Yeah, absolutely. So MLA, we don't have any clear cutoffs, but we can compare to the healthy segment of the vessel if there is any. We know that there are certain MLAs for proximal LAD or left main even that should be there after lesion preparation or after stenting. So I think it's only practical what we do now. We need more data. And I think there are many trials coming up. But the problem is also that the current software are not optimized for DCB treatment. You have to actually measure MLAs by hand drawing in IVUS or OCT imaging. So what we need is an algorithm which is AI-based, automatic, to enable better evaluation, because there are dissections, so it makes it more difficult to measure MLA as compared to stenting.
Yeah, so this is also something. It's not a complete. It's not a clean tube. No, that you have some irregularities in the lumen with the dissections, and sometimes this is more difficult to measure the actual flow area. So yeah, you're completely right. So there are many questions that we don't have time to address. We are in the last minute of the webinar. I just want to thank you all for the great presentations and for the clarifications. I want to thank you all the colleagues that joined the webinar that posted a lot of questions. As a summary, I would say that really the Novo trial, I really believe, is a breakthrough, and basically because it brings evidence to tell us that there are more options for our patients. That we have now more options to treat our patients, which is our main purpose in our daily work. So I think it was very interesting also to understand from 3 very experienced operators in the use of DCB in the Novo lesions, which type of patients are they treating with DCB and which type of lesions. So how to select the correct patients. With this, I would like to thank you again. Thank you all. I think as I mentioned, I think basically this is going to improve the quality of PCI, both for TCB and also stents. So thank you all for joining, and see you very
Thank
soon.
you.
Thank you.
Thanks. Bye.